let's move on into chapter 18, part B. And let me fix my pointer right there. You got my pointer right there. And we're going to get into the next slide. We're now going to discuss the intrinsic cardiac conduction system and the action potential succession that is actually happening in one heartbeat. How does the human heart contract? We all know that probably from grade school or even from middle school, you know already that your heart rate has its own independent contraction system. How does it contract? The heart, the heart contracts using a coordinated uh, um, the coordinated work of gap junctions, and it forms pretty much what you call the intrinsic cardiac conduction system, and that is made up of a network of non-contractile. These are actually autorhythmic cells that initiate and distribute impulses to coordinate depolarization and contraction of the heart. So your action potential is initiated by pacemakers. You call these the pacemakers. You call them the SA node and the AV node, but they are actually pacemakers. Cardiac pacemakers, we call them cardiac pacemakers. They have unstable resting membrane potential, and you call them the pacemaker potential or the prepotentials. And there are three parts of action potential in a cardiac muscle itself. First, you have the pacemaker potential. This is when the calcium channels are closed, but the slow sodium channels are open, causing the inferior to become more positive. You remember all the jazz of this, and then depolarization happens. And then the depolarization happens when the calcium channels open, which happens around 40 millivolts, allowing the huge influx of calcium, leading to a rising phase of action potential. Then after the depolarization, which is actually contraction, the muscle needs to relax. So it will now initiate the repolarization where your potassium channels will open, allowing the efflux of potassium, and the cell becomes more negative. So the sequence of excitation, the cardiac pacemaker would pass impulses in the following order, which I will be mentioning in approximately 22 seconds. So first it goes into the SA node. That is your SA node right there. I'm pointing to it. Then it contracts and sends signal into the AV node right there. And then from the AV node, it will get into the atrioventricular bundle, and then it will get into the right and left bundle of His, and then the right and left bundle of His will now be um, branching off into the Purkinje network. The SA node, this first one here, initiates the contraction. It is found on the heart in the right atrial wall. It depolarizes faster than the rest of the myocardium. It usually generates an impulse of about 75 times per minute. That's actually what you call the sinus rhythm. And it is at an inherent rate of about 100 times per minute. It is tempered by extrinsic factors, and the impulse spreads across the atria. It spreads all the way and into the AV node. So the AV node is actually receiving it. The AV node, this is actually AV node, is in the inferior intra-atrial septum. It delays impulses by about 0.1 of a second because the fibers are smaller in diameter and they have a fewer gap junction, and therefore the amount of electrical activity that flows through it becomes less. So it slows down in that area. At this point in time, it allows the atrial contraction prior to ventricular contraction. If there won't be any slowdown there, then both the atria and the ventricles will contract together, or maybe the difference between them will be less than what it is now. But because of the slowdown, this is really very good. There's actually a slowdown. The atria contracts. There's a little bit of slowdown because before the ventricle can contract. It will allow the feeling, the blood is not going to fill into the ventricles before the ventricles contract. It allows a rhythm of alternation. It alternates. There's an alternation between the contraction of the atrium, the atria, which happens first, and then the ventricles, which happens next. The atrioventricular, the AV bundle of his is actually, there you go, this is the AV bundle, and then the bundle of his is located in the superior interventricular septum and is the only electrical connection between the atria and the ventricles. Since the atria and the ventricles really are not connected via gap junctions. Now, the right and left bundle branches, these right and left bundle branches, there are two pathways in the interventricular septum. They carry impulses towards the apex of the heart. And the endocardial conduction network, which is referred to as the Purkinje network. You can see that right there in the heart muscle, in the ventricular muscle, completes a pathway through the interventricular septum into the apex and the ventricular walls. And they are more elaborate. The Purkinje network is more elaborate on the left side of the heart. The AV bundle and the subendocardial conducting network would depolarize 30 times a minute in the absence of an AV node input. So let's take a look at some homeostatic imbalance. These are defects in intrinsic conduction system and may cause what you call arrhythmias. Arrhythmias are irregular heart rhythms, and this is actually uncoordinated atrial and ventricular contractions. Fibrillation, which is an arrhythmia, is a rapid irregular contraction. This is when the heart becomes useless for pumping blood. It causes the circulation to cease completely and may result in brain death. And the treatment for fibrillation will be defibrillation, and you can see a lot of defibrillators around now. Even our own school, in the pathway to every classrooms, you have um, um, a small defibrillator, which will probably help somebody who would know how to use it to defibrillate a heart that is actually having a person having a heart attack. Now, the treatment for fibrillation is defibrillation. That's actually why we have all of those things around our campus. It interrupts the chaotic twitching, giving the heart a clean slate to start regular, normal depolarization again. So, right here, um, pretty much you have what you call a defective SA. Um, uh, it actually shows us something about a homeostatic imbalance. A homeostatic imbalance that will happen if you will have an ectopic focus or an ectopic pacemaker. What is an ectopic pacemaker? Well, an ectopic pacemaker is an abnormal pacemaker that takes over the pacing. See, usually you have your SA node right there. Supposedly, that is supposedly your pacemaker. What happens in an EKG if you have an ectopic pacemaker? It would show a, let me see, something like a, um, what do you call this? A a QRS, or a ventricular peak right there without without your SA node, or you can just have an SA node without anything at all. See, you have all here. You are It's showing that you have something that is normal. You have a normal QRS, another normal QRS. Then all of a sudden here you have a premature ventricular contraction pretty much this means that there is something that initiated this particular QRS without your P wave. And here you have another. Here is another ectopic focus. This time it is a premature atrial contraction. So you have an atrial a P wave that is not supposed to be there, but it actually initiated a contraction that is not supposed to be. This ectopic focus causes extrasystoles. These are what you call premature contractions. An ectopic focus of small origin of the heart triggers an impulse before the real SA node can actually trigger its own. It causes delay in the next impulse. The heart, at this point in time, if you will have ectopic focus, the heart has no longer or has a longer time to feel, so the next contraction is felt as a thud, and a larger volume of blood is being pushed out. This is due to the probably to excessive caffeine or nicotine, um, and it is known now that ectopic focus is actually caused by um, caffeine or probably nicotine accumulation in the heart muscle. And right here, you have a good background on the electrocardiogram. It tells us exactly what probably would cause a heart attack. Well, before we get into the causes of the heart attack, probably the signs and symptoms of probably a person that would probably have some heart problems would be fatigue, dyspnea, chest pain, or pretty much hypotension, bradycardia, which means the heart rate is very slow, and there's actually hemodynamic instability. And these symptoms are probably like something that a regular person um, would just not mind, but it can cause heart attack. Now, heart attack are disorders affecting the heart muscle walls. It's inflammation of the heart muscle walls. It's also pretty much like an infection already of the inner layer of the heart. It's an inflammatory condition, and pretty much for the most part, a heart attack might need some cardiac surgical procedures depending on what is causing the heart attack. So let's try to look at the extrinsic innervation of the heart. And the heartbeat is modified by the autonomic nervous system via the cardio acceleratory center and the cardio inhibitory center. The cardio acceleratory center sends signal through the sympathetic trunk to increase both rate and force. It stimulates the SA and the AV nodes, the heart muscle, and the coronary arteries. On the other hand, the cardio inhibitory center is when the parasympathetic signals or throws in parasympathetic signals via the vagus nerve. There is actually a vagus nerve right there. Okay, so this is actually your cardio inhibitory line to decrease heart rate. It inhibits the SA and the AV nodes via the vagus nerve. The action potentials of contractile cardiac muscle. The difference between contractile muscle fiber and skeletal muscle fiber contraction is pretty much has already been pretty much like discussed also in your AMP1, or you have practically read on it if you were actually on an online class. The action potential in skeletal muscle would last about 1 to 2 minutes. In a cardiac muscle, it lasts about 200 milliseconds, and that's actually quite a difference in speed. Contraction in skeletal muscle would last about 15 to 100 milliseconds. Meanwhile, contraction in the cardiac muscle would last over 200 milliseconds. That's actually very long. Now, the benefit of longer action potential and contraction are the following. First, you have sustained contraction that ensures efficient ejection of blood. And then you have longer refractory period, which prevents tetanic contractions. An EKG or an electrocardiograph can detect electrical currents that is generated by the heart. And since you are not able to do EKGs in a real lab, you are going to be looking at EKGs that you will be doing in some interactive physio X. I call it the physio X lab. So you're going to do this in the lab, so you will know exactly what an EKG reading would look like. It will generate real readings, so you will understand what a reading is all about. You can also um, calculate the heart rate using an EKG reading, and you will find out exactly how to do that in your lab. An electrocardiogram or an EKG is a graphic recording of the electrical activity, and it is composite of all the action potentials at a given time. It is not a tracing of a single action potential. It is actually composite. The electrodes are placed at various points on the body and they measure voltage differences. And we call this, and it was initiated as a 12 lead EKG. That was actually the most typical. It was the first type of electrocardiogram since I could remember it, and I had been teaching already for a long time. But now they even have already EKGs that's only like 4 lead EKG, and each of the leads are more sensitive, that are capable of picking up all of the action potentials of a 12 lead EKG. This is a gentleman showing you, in this picture is a gentleman showing you the showing you of the being that's actually being his EKG is being taken using a 12 lead EKG. Those are the leads of the EKG. So let's take a look at an EKG tracing. This is your EKG tracing. And an EKG tracing is made up first of the P wave. That's actually your P wave there, which is representing the depolarization of the sinoatrial node. And then your QRS, this is your QRS. This is actually a complex wave made up of 3 waves, 2 negative. Q is negative, R is positive, and another negative deflection, the S. The QRS, they are called cumulatively as the QRS complex, and is accounted for by the ventricular depolarization as well as an atrial repolarization. Remember, this is your atrial depolarization. There must be a repolarization. The atrial repolarization is somewhere here, and you cannot see it independently as a single wave because it's mixed in with the wave that is being produced by the ventricles. And the ventricles are huge muscles, and therefore they can mask the depolarization of the atria. So here you have the depolarization. The repolarization of the atria is being masked by the depolarization. This bizarre QRS complex is the depolarization of the ventricle, and your atrial repolarization is also inside there. The T wave, which is the last wave right here at the far end, pretty much is actually the ventricular repolarization. The PR interval. Now, this is how to pretty much like appreciate what an EKG is. The PR interval is the interval beginning of an atrial excitation to the beginning of the ventricular excitation. And then your ST, this is actually your ST segment. The ST segment is the entire ventricular myocardium that's already been depolarized. The QT, this is actually Q, there's a QT. Your QT, the QT interval is the beginning of the ventricular depolarization through ventricular repolarization. So what is the purpose of these intervals? Well, these are all standardized lengths. And if your heart is actually doing an entire contraction, it it will have to be finished by 22 milliseconds. But sometimes, if there's actually something wrong with your heart, if there's something wrong with the PR interval, which means that if this is longer than what it should be, if it is should be something like your PR interval should be about zero point 0.2 milliseconds. I could see that zero point 0.2 right there. If it takes longer than zero point 0.2 milliseconds, there must be something wrong that's keeping the signal from the P wave from being received by your ventricle, which is actually um, already a defect because it should not be. The heart must, rather the AV node must receive the signal from the atria and must contract within zero point 0.2 milliseconds. If it doesn't do that, something is wrong. In between there's something like a block that is blocking the signals from the P wave from getting into the QRS. Pretty much that's only one of the things that you can actually do in handling an EKG. And there are so many other things. If you have an ST segment right there, a depressed ST segment, the character, this is a regular, the, the PQRST wave, the EKG wave, is standard for every human being. If there's actually something wrong with your heart, you would know it immediately if the shape of your EKG is not normal. If you have a depressed ST segment, that is already like something that would warn a clinician that there is something wrong with your heart muscle. Injury to the heart muscle usually significantly uh, people or patients that would have a depressed ST segments will have injury to the heart muscle. If you have little, an additional PQRSTU, you call that a U wave. If you have an additional U wave right there, well, you're not supposed to have an additional wave there, then for the most part, would they would pretty much say, oh, there's something wrong, and they they found out that an additional wave, which they call the U wave, is brought about by hyperkalemia or what do you call this? Where your blood has a lot of potassium in it. There you go. So right here is actually one of the homeostatic imbalances. There may be changes in pattern or timing of EKG that would reveal diseased or damaged heart because your EKG pattern waves, your EKG waves are supposed to be normal. Problems such as an enlarged an R that would be wide may indicate an enlarged ventricle, and it's not supposed to be. An elevated or depressed ST segment indicates cardiac ischemia or pretty much your heart has been injured, heart muscle has been injured already. And prolonged QT segment from Q to the T would actually indicate a repolarization abnormality that increases the risk of ventricular arrhythmias. So this is your normal EKG pattern. Anytime that you will have something that would not look like this, then something is wrong. This is actually an abnormal EKG, something that we call junctional rhythm. The SA node is non-functional here. You don't have any P wave. You cannot see any P wave. You see only RST waves. The AV node paces the heart at about 40 to 60 beats per minute because there's nothing that's going to make them beat a little bit faster. Your SA node is non-functional here. Then you have here a second degree heart block. This one here is when the AV node fails to conduct some SA node impulses, which means there are more P waves. You can see the P waves. Okay, you can see the P waves, but you cannot see much of the QRS. The QRS would only the QRS is actually the work of the ventricle. And when there is nothing that's going to stimulate the ventricle, there's no atrial depolarization that's going to stimulate the ventricle. Usually, the ventricle will just wait to be completely full, and that's the only time it's going to contract, even without the SA node contracting. And thus, you see you see um, a contraction pace that is actually prolonged for each one. And oh, that was actually fibrillation. That was uh, that I did not even manage to explain to you. Where the heart is, where the the heart is actually like jiggling and it's not really contracting at the pace it's supposed to be. Now, let's take a look at completely the mechanical events that is actually happening inside the heart. When the heart is in systole, that's actually the period of heart contraction. Usually, when you say systole or systole, we refer that to the contraction of the ventricles. Diastole or diastole is referred to the period of heart relaxation. This is when the ventricles are relaxed. Cardiac cycle is the blood flow through the heart to one complete heartbeat. First, you have your atrial systole, and then diastole, followed by ventricular systole and diastole. A cycle represents a series of pressure and blood volume changes. The mechanical events that follow, they follow usually the electrical events that you see in an EKG. And there are three phases of the cardiac cycle, starting from the left side, okay, and then the left, rather, the starting with total relaxation from the left side, and we will see it, okay. So the first thing that's going to happen is ventricular filling. Is when the ventricles will start to fill, and that's already in the mid to late diastole. The ventricles are relaxed; they are in diastole. Okay, the pressure is very low. 80% of the blood is going to passively flow from the atria through the open AV valves into the ventricles from the atria to the, and the semilunar valves are actually closed here. So the blood is actually coming from the atria and they are just passively flowing down into the ventricles. Atrial depolarization triggers the atrial systole, which means this is when the atria will now contract. The atria will push the remaining 20% of the blood into the ventricles. So the atria is actually passively being just receiving blood from the veins, and then as it receives blood from the veins, the blood is now going to drop into the open semilunar valves. I mean semilunar atrioventricular valves. My apologies. So the AV valves are open and the blood gets into the ventricles anyway, and that whole 80% goes there passively. Now, when the atria contracts, it will contract the remaining 20% into the ventricle. So now it has the entire 100% into the ventricle. Now, you now have the ventricles to be filled up. That ventricular volume that is already there at the end of the diastole of the ventricle is what you call the end diastolic volume. It is the volume of blood in each ventricle at the end of the ventricular diastole. Now the depolarization spreads into the ventricles, and this is actually what is causing the QRS wave. The QRS wave, this is the P wave, that's your QRS wave, is actually produced when the depolarization of the ventricle happens. The depolarization of the ventricle happens whenever the ventricles contract. The atria finishes contracting, returns to its diastole, this time while the ventricles actually is in systole. So, isovolumetric contraction. The isovolumetric contraction happens when the atria while the atria is actually relaxed. Okay, the ventricles will now begin to contract. The isovolumetric contraction is somewhere right here. This will now have rising ventricular pressure. This is actually when your ventricles are now already like almost filled up, all right, and it's already starting to contract. Now, the isovolumetric contraction is a split second phase when the ventricles are completely closed, which means the AV valves are now closed and your semilunar valves are still closed. So your ventricles are already filled with blood and it initiates its contraction. When it initiates its contraction, the first thud or the first sound that you will hear will be the closure of the AV valve. The closure of the AV valve, but then your next sound will come later, which is the opening of the semilunar valve. It doesn't come until your until your heart passes the isovolumetric contraction phase. This is only a split second phase. The split second phase. After this, you have your semilunar valve will now be open. Remember that the semilunar valve opens only after it overcomes the pressure that is behind the semilunar valves. Now your pulmonary trunk right here, you can see that the pulmonary trunk doesn't have anything inside, but it's not. It is still filled with blood. That pulmonary trunk has blood in it. It's not empty. So your left ventricle will need to contract at a force that can open that semilunar valve right there so the blood can be ejected into the pulmonary trunk. And that would have about 10 millimeters of mercury pressure. That's really very high. Meanwhile, in your what do you call this? In your in your left ventricle, the blood in the left ventricle will go into the aorta. And the aorta is not empty, it has blood in it. And usually the blood pressure inside the aorta is about 80 millimeters of mercury pressure. So your ventricles, your left ventricle will need to contract at a much higher force to open the aortic semilunar valve, and the right ventricle will need to contract at a much higher force to open the pulmonary valve. Both valves are actually like kept closed by the by the pressure that are inside the large arteries, and the ventricles will need to make sure that when they contract at a force that is um, much higher than the pressure that is inside the large arteries. So right here, when the left ventricle contracts, the pressure in the aorta would reach about 120 millimeters of mercury pressure. Okay, before it was 80, it will become 120 millimeters of mercury pressure. If you know, if you realize what these numbers are, this is actually the numbers of your blood pressure. Okay, 120 is what you call the systolic pressure. 80 is actually what you call the diastolic pressure. Systolic pressure is actually the pressure in the arteries when the ventricles are in systole. This is actually the pressure that allows the left ventricle to empty the blood into the what do you call this into the aorta. And meanwhile, the 80 millimeters of mercury pressure is a pressure in the aorta when your ventricles are in diastole. So, following okay, after the isovolumetric, we're now going to get after the isovolumetric contraction. It's now going to be followed by the isovolumetric relaxation, and pretty much following a ventricular repolarization, your T wave, you got your T wave right here already. pretty much it will show that the ventricles are already relaxing. So your isovolumetric relaxation is somewhere around this area right there. And it pretty much it would also show right there the end systolic volume. The end systolic volume is the amount of blood that is right there, this right here in this area here, is the amount of blood remaining in each ventricle after it has emptied itself into the big arteries, which means um, it's a volume of blood remaining in each ventricle after it has contracted. The ventricular pressure drops, causing a backflow of blood from the aorta and the pulmonary tract that triggers closing again of the semilunar valves. The ventricles are completely closed, the chambers momentarily pretty much um, are relaxed, and this is actually now your isovolumetric relaxation phase. The closure of the aortic valve would raise the aortic pressure as backflow rebounds off the closed valve cusps, and this is referred to as to the dicrotic notch. The atria continue to fill during the ventricular systole, and when the atrial pressure exceeds ventricular pressure, the AV valve opens. The cycle begins again. The heart beats about 75 times per minute. One cardiac cycle would last about zero point 0.8 of a second, and the atrial systole lasts about zero point 0.1 second. The ventricular systole lasts about zero point 0.3 seconds. The quiescent or the quiescent period is a total heart relaxation that would last about zero point 0.4 seconds. Now, the events of the cardiac cycle again is in animation, and it is actually in your study room, and I will explain to you, or as I have explained to you how to use it in our um, um, the first day during our first day. So let's take a look at the heart sounds. The heart sounds are associated with the closing of the heart valves. The first sound is the closing of the AV valves and the beginning of the ventricular systole. The second sound is the closing of the semilunar valve at the beginning of the ventricular systole. And there is a pause between them, which indicates that the heart is actually relaxing. The mitral valve the mitral valve or the bicuspid valve closes slightly before the tricuspid, and the aortic closes slightly before the pulmonary valve. The differences would allow hearing of each valve when a stethoscope is present in four regions. And if you are trained to do that, you will be able to distinguish the differences. Heart murmur refers to the abnormal heart sound heard when the blood hits obstructions. Usually, it indicates valve problems. When there's actually what you call incompetent. Okay, you let me tell you something about heart murmur because I used to have heart murmur. There's um there's actually an abnormal sound usually that the doctor hears in me when I was really very young, when I was young, and I outgrew it because I am very small. I am short and I'm very little. My rib cage is very and my heart is really very small. And and probably that's the reason why I had it. But according to the doctor, that's the reason why I had the heart murmur because I'm small. It usually indicates a valve problem, but I was able to outgrow it. There is actually incompetent valve, and usually it fails to close completely, and it allows a backflow of blood, which the clinicians would hear as a murmur. It's actually like um, a water faucet, a dripping water faucet. It's somewhat like the swooshing sound of blood. So this is actually happening when the blood regurgitates backward from the ventricle into the atria. Now, which is actually different from this thing here that says stenotic valve. This is actually when a stenotic valve usually fails to open completely, It restricts blood flow through the valve, and pretty much it causes a high pitched sound or a clicking as the blood is really forced through the narrow valve. Now we go to the cardiac output. We're now going to discuss how um, blood flow is actually into the heart is actually regulated. How do we measure the amount of blood that is actually getting into the heart and is pumped out of the heart? How good is the pumping power of our heart? How hardworking is our heart? We will understand how hardworking our heart is when we understand what the cardiac output is all about. The cardiac output is the amount of blood that is pumped out by each ventricle per minute, and it is equal to the heart rate times the stroke volume. And what is the stroke volume? The stroke volume of the blood is actually the amount of blood or the volume of blood that is pumped out by one ventricle with each beat, and it correlates with the force of contraction. For instance, we have here a formula showing us that cardiac output is your heart rate times the stroke volume. An average heart rate is about 75 beats per minute, and the stroke volume, which is the amount of blood that is being pumped by the ventricle, is 70 ml per beat. So pretty much per minute, uh, if you multiply 75 by 70, you will come out to about 5.25 per minute. Think about this. 5.25. That is actually 5 liters per minute. You could just imagine 5 liters of blood flowing into your heart in 5 minutes. How awesome can your heart be, right? The maximal cardiac output is 4 to 5 times when you have resting cardiac output, and is usually in a non-athletic person is usually only about 20 to 25 liters per minute. Oh boy, that is really a lot. 20 to 25 liters per minute flowing through my heart, that's a lot. But when you are athletic, your cardiac output will be higher. That means your heart is actually pumping more blood and is more efficient. It can reach up to about 35 liters per minute in a trained athlete. Wow, that is really good. And this is actually how your blood is actually being circulated by your heart. So what are the factors that would determine cardiac output? Well, there are many factors that affect cardiac output. Any factor. Remember that your cardiac output is your heart rate times the stroke volume. So anything that's going to affect your heart rate and your stroke volume will also increase your cardiac output. For instance, exercise. Your exercise can actually can be increased by sympathetic activity. It will increase the skeletal muscle and respiratory pump. It will increase the venous pump. The return of blood is increased. It will increase the end diastolic volume, which is actually your preload, which will increase the stroke volume. When your end diastolic volume is increased, then it will increase your stroke volume. When a stroke volume is increased, your cardiac output will increase. Then let's go to somewhere here. What about changes in the autonomic and central nervous system output in response to exercise? That is still exercise, right? That's still exercise. Well, let's go here. Blood-borne epinephrine. Blood-borne epinephrine. That means you have an increase in blood-borne epinephrine, or maybe thyroxine. Let's say blood-borne epinephrine. That means you're excited. You're excited, or you are under stress. Your epinephrine is high. Okay, that will increase the contractility of your muscle. That will reduce the end systolic volume. When your end systolic volume is low, even if your end diastolic volume is not changed, that would increase still your stroke volume. It could end up in increased cardiac output. So an increase in sympathetic activity pretty much would increase your um, if anything that increases contractility of the heart will actually pretty much result to an increase in stroke volume. A decrease in parasympathetic activity or increase in sympathetic will increase heart rate. And once your heart rate is increased, then your cardiac output is also increased. So here's actually just words to remember in stroke volume before we leave cardiac output, because we're going to get into stroke volume. The next topic that we're going to get into will be stroke volume. Let me emphasize to you, the end stroke volume is actually the key parameters in the stroke volume is your end diastolic volume and your end systolic volume. The end diastolic volume is the volume of blood in the ventricle at the end of a diastole, which is a period when the ventricle is relaxed and filling with blood. It represents the maximum amount of blood the ventricle will hold before it contracts. The end systolic volume is the volume of blood that remains in the ventricle at the end of a systole, which is a period when the ventricle is contracting and ejecting blood. It's the minimum amount of blood in the ventricle during a cardiac cycle. So, your stroke volume, mathematically, is the volume of blood pumped out by each ventricle with each beat, and it correlates with the force of contraction. And it is the end diastolic volume minus the end systolic volume. And normal stroke volume is about 70 ml per beat. If your end diastolic volume, that's it, is about 120 ml, so your ventricles will fill up at the end before it contracts at the end of its diastole. It's now 120 ml, and then it contracts. The remaining blood that's in there will be your 50 ml, that is your end systolic volume. You deduct that from the 120, which is your end diastolic volume, then your stroke volume is 70 ml per minute. This is now the amount of blood that just left the heart or the ventricle itself. And there are three factors that would affect the stroke volume of the heart: preload, contractility, and afterload. Preload refers to the degree of stretch of the heart muscle. Preload is a degree to which cardiac muscles are really stretched just before they contract. Changes in the preload will cause changes in stroke volume. Changes in the preload affects the end diastolic volume. Changes in the preload would pretty much affect also the relationship between your uh, preload and the stroke volume, which is called the Frank-Starling law of the heart. The Frank-Starling law of the heart describes how the heart's stroke volume, the amount of blood that's pumped out in each beat, increases in response to an increase in volume of blood filling the heart, which is the preload. Essentially, the more the heart muscle is stretched by incoming blood within physiological limits, the more forcefully it will contract, leading to a greater stroke volume. This intrinsic mechanism allows the heart to adjust its output to match the venous return, meaning it pumps out what it receives. If it does not pump out what it receives, and there's going to be more blood that is left, that means something is wrong with our pumping, with the pump itself, with the heart muscle. A good heart muscle with good elasticity and everything will pump out as much as it can so that it can receive as much as it actually um, as much as it actually released, or as much as it actually pumped out. It should also be receiving as much. If something is wrong with the heart muscle, then if the heart muscle becomes weaker, then the stroke volume becomes less and less. Most important, again, the Frank Starling law of the heart describes how the heart's stroke volume, the amount of blood that's pumped out its heart, increases in response to an increase in volume of blood filling the heart, which is actually called the preload. Essentially, the more the heart muscle is stretched by incoming blood, the more forcefully it will contract, leading to a greater stroke volume. So, uh, an increased in venous return distends and stretches the ventricles and increases the contraction force. That's actually your Frank Starling law. Contractility is a contractile strength at a given muscle length and pretty much independent of muscle stretch and and diastolic volume. Increased contractility lowers the end systolic volume. It's caused by sympathetic epinephrine. It, it releases and it stimulates increased calcium influx, leading to more cross bridges formation. Positive inotropic agents would increase contractility, for example, thyroxine, glucagon, epinephrine, digitalis, and high extracellular calcium. Contractility is decreased by negative inotropic agents such as excess hydrogen ion, increased extracellular calcium, extracellular potassium, and then calcium channel blockers. Afterload is the resistance the heart must overcome to pump the blood into the arteries. You remember when I mentioned to you that the arteries were not empty, they are filled with blood. While the heart is going to be pumping blood into the arteries are not waiting, not with blood, with no blood in it. There's already pre-existing blood in it. And it's actually exerting pressure over the semilunar valves of the large arteries and keeping it close. So essentially, the resistance that the heart must overcome to pump the blood into the artery is what you call the afterload. It's the back pressure exerted by the arterial blood. And the back pressure from the arterial blood that's pushing on the semilunar valve is actually a major pressure. It's about 10. Um, it's about, well, in the large arteries, in the aorta for itself, the aortic pressure is around 80 millimeters of mercury pressure. And then in the pulmonary trunk, it's around 10 millimeters of mercury pressure. Now, hypertension increases after load. It results in increased end systolic volume and reduced stroke volume. If the stroke volume, if the stroke volume decreases as a result of decreased blood volume or weakened heart, cardiac output can be maintained by increasing heart rate and contractility. Positive chronotropic factors can increase or will increase heart rate, while negative chronotropic agents can actually decrease heart rate. This effect is primarily mediated by the autonomic nervous system, which can adjust heart rate to meet varying demands. The heart can be regulated by three systems: the autonomic nervous system, some chemicals, and some other factors. The autonomic nervous system regulation of the heart is brought about by the sympathetic nervous system and its hormone, the norepinephrine. The sympathetic nervous system can activate or is activated by emotional or physical sensors, and pretty much norepinephrine is released. And when norepinephrine is around, it causes a generalized increase in pacemaker activity and contractility. Because here the end diastolic volume and the end systolic volume will decrease and the systole will actually be changed. The parasympathetic nervous system, on the other hand, will oppose the sympathetic effect. This is brought about by the hormone acetylcholine of the parasympathetic division. It hyperpolarizes pacemaker cells by opening calcium channel, which slows down heart rate, but a little to no effect on the contractility of the heart. The autonomic nervous system of the heart pretty much would give the heart also a heart that is at rest its vagal tone. The parasympathetic is a dominant influence on the heart rate. It decreases rate about 25 beats per minute. It causes the vagal nerve leads to heart rate of about more or less 100 beat, beats per minute. Another way of explaining this is uh, the Bainbridge reflex. It's also known as the atrial reflex. It's a cardiovascular reflex that increases heart rate in response to increased volume and pressure in the atria of the heart. This reflex helps the heart adjust its output to match the incoming venous return and thus ensuring efficient circulation. This means that when the sympathetic nervous system is activated, the parasympathetic is inhibited, vice versa. The atrial reflex is when the sympathetic reflex that is initiated by increased venous return would result in increased atrial filling. The atrial walls are stretched with increased volume. It stimulates the SA node, which increases heart rate and also stimulates atrial stretch receptors that would activate the sympathetic reflexes. Okay, this is another one, but pretty much it's the same thing that we discussed already. Okay, let's take a look at the regulation of heart rate. Now we finished with the regulation of stroke volume. Let's take a look at the regulation of heart rate. There are there's also the chemical regulation of heart rate, and we start with the hormones. Epinephrine, for instance, is from the adrenal medulla. It increases heart rate and contractility. Thyroxine increases heart rate. It enhances the effects of norepinephrine and epinephrine. Ions, you have intra and extracellular ion concentration. For example, your calcium and potassium must be maintained for normal heartbeat function. Imbalances of these ions, potassium and calcium, is very dangerous to the heart. Hypokalemia, a decrease in calcium blood levels, would depress heart activity. Not hypokalemia, hypocalcemia is a decreased level of calcium and it depresses heart activity. Hypercalcemia is an increase in calcium level and the heart rate, it increases heart rate and contractility. Hypercalcemia. Hyperkalemia is an increase in potassium. It alters electrical activity, which can lead to heart block and cardiac arrest. Hypokalemia is uh, um, a decrease in potassium and results in feeble heartbeat arrhythmias. There are other factors that influence heart rate. You have gender, age, exercise, body temperature. With age, let's take a look at age. The fetus has the fastest heart rate. It declines with age. With gender, the females have faster heart rate than males. With exercise, you know that exercise increase heart rate would increase heart rate, and trained athletes can have slow heart rate. Body temperature, um, heart rate would increase with increased body temperature. And here you go, more of the words that you need to remember in homeostasis of the heart. Tachycardia is an abnormally fast heart rate, which is abnormally beyond 100 beats per minute. Bradycardia is when the heart rate is slow, slower than 60 beats per minute. Congestive heart failure is a progressive condition. This is where a cardiac output is low, that the blood circulation is inadequate to meet tissue needs. It reflects a very weak myocardium that is caused by coronary atherosclerosis. That's actually clogging of arteries caused by fat buildups and impaired oxygen delivery to cardiac cells. The heart becomes hypoxic, it contracts inefficiently. And then the next one is your persistent high blood pressure. Aortic pressure here is about is greater than 90 millimeters of mercury pressure. It causes the myocardium to exert more force. There's chronic increased end systolic volume, and it causes the myocardium to be hypertrophic and weak. Then you have multiple myocardial infarcts. This is when the heart becomes weak as contractile cells are replaced with scar tissues. Then you have your dilated cardiomyopathy. The ventricles would stretch and become flabby, and the myocardium deteriorates. This is brought about by drug toxicity or chronic inflammation, and pretty much either side of the heart can be affected. When there's actually left side failure, it results in pulmonary congestion. The flood backs up in the lungs. Right sided failure results in peripheral congestion. The blood pools in the body organs. Failure of either side ultimately weakens the other side and leads to a decompensated and seriously weakened heart. A treatment will be to remove the fluid and drugs, of course, to reduce afterload and increase contractility. So, regular exercise can always keep your heart healthy. Age-related changes would include sclerosis, which is a thickening of heart valves, leading to heart murmur, decline in cardiac reserves, so the heart becomes less efficient, fibrosis of cardiac muscle, which leads to stiff heart arrhythmias caused by conduction system problems, and then atherosclerosis, which may be averted by good diet, pretty much. And I think we are already on the end, and I will see you in the next chapter.